Hello, welcome to your lecture on adult depression. Now, depression is a primary mood disorder. It's characterized by a depressed mood or decreased interest in things that used to give pleasure. It's usually defined during a 2-week period, and it does represent a change from previous functioning. What you need to realize is that most people who come into primary care are not going to come in and say that they're depressed. They're going to come in with other symptoms. They're going to worry about a medical illness, or they're going to have physical complaints, which we call somatic symptoms, such as fatigue or insomnia, or maybe sleeping too much if it's atypical depression. Epidemiology, it's the fourth most common reason to visit primary care. If you aren't diagnosing a lot of depression, then you are just missing it because it's there, and lots of times people will come in for, like I said, other physical complaints and reasons. It's most female, 2 to 1. It affects about 78 million in the U.S., and over a lifetime you have about a 15% risk of developing a major depressive disorder. When it comes to the pathophysiology, there's actually a very cute little movie that I put in the module, The Signs of Depression. And I kind of did some reading about genetics based on what I saw in this particular video, and it's cute and it's short, but it's actually very accurate as well. So take a look at that. I think it does a good explanation of what we know about depression right now. In the past, we've always thought it was impaired synthesis or metabolism of neurotransmitters. Now we're not so sure that it's not more the links that are going on in the brain. Now, most of our medications are based on norepinephrine, serotonin, and dopamine. Serotonin tends to produce a lot of calmness and relaxed states, and dopamine and norepinephrine tend to enhance productivity, ambition, and ability to concentrate. So based on what the kind of symptoms your patient is having will help you determine which medications would be most efficient. We always have to talk about the genetic basis because it's so much more common when you have a first-degree relative with depression. That's always something that you want to ask when you think depression is your primary diagnosis. And when it comes to prescribing medications, it never hurts to ask, if your mother's on a medication, what is it that's helping her? What has she found? I mean, most of the time you can go with an SSRI and it's going to work really well, but if you can, narrow that down a little bit by asking about what works with a first-degree relative, then that's just a better starting point. Risk factors, there's a lot of these. Predominant age starts in the late 20s, although that is getting earlier and earlier in life. We know that the elderly over the age of 65 tend to have more depression, especially those that are in long-term care. But it also has to do with their health, and we know that presence of chronic disease or presence of chronic diseases increases their risk of depression. We also have them on multiple pharmaceuticals that are going to influence their risk for depression, and we're going to talk a little bit about medications, but how can you have somebody on 13 different medications and have any idea about what's interacting with what? So a history of behavioral disorders, presence of chronic disease, especially with diabetes. There's a threefold increase depression with diabetes, and it's something that you always want to ask your patients about. They've done a lot of research recently on recent MI, cabbage, stroke, those kinds of things, and they definitely increase your risk. Strong family history of depression, bipolar, suicide, alcoholism, any substance abuse, domestic abuse or violence, personal substance abuse and dependence. Lots of times people self-treat for depression and other mental disturbances, and that turns into an abuse and dependence. Losses and stressors, of course, grief, single, divorced, or unhappily married are just more likely to be at risk for depression. And then, of course, genetics, and we talked about that, I think, with the family history.
When it comes to screening and prevention, the U.S. Preventive Services Task Force does advise screening for depression. But one of the things that you need to know is how common it is and that there are known protective factors. So there are lots of things that you can talk to your patient about remaining healthy and to help prevent some of these issues that come up. We know that regular exercise makes a big impact and that people who are exercising on a regular basis are much less likely to suffer from depression. Patients with social support, a healthy diet, and those who are avoiding substance abuse are also less likely to develop depression. So, doing screening and then also talking about prevention is an extremely important part of what we do in primary care. There are some offices, and I've worked in a clinic where when a patient came in, they automatically got a PHQ-9, especially if they were a new patient. And that was actually very helpful, because when someone comes in with lots of symptoms, they kind of don't match up. If you have that PHQ-9 and it shows that there's some depression, then that's a better starting point for you when you walk into the room. Now, I would also have my assistants go ahead and give the PHQ-9 to patients who came in with a lot of symptoms, even though they weren't new patients, and that also just was a good screening.
Differential diagnosis for depression can actually be huge. It would be great if they came in and said, hey, I'm depressed, and then you went from there, but lots of times they come in with all these physical complaints that don't match up, and you eventually have to get to depression and then figure out your differential diagnosis. So usually it's very much a 2 or even a 3-step process to figure out what's going on. First thing you have to think about is medication use, especially in your elderly who are on lots of different medications. It could be influencing the depression. Antiarrhythmics, barbiturates, central nervous system depressants, beta blockers, cholinergics, corticosteroids, DIG, H2 blockers, a lot of different medications. One of the things that you're going to find is, especially a lot of your elder patients may be on a benzodiazepine, and they were probably given that sometime when they were much younger, and that was for anxiety. They feel like that they absolutely have to have it, but what it does is over a period of time it increases their depression. So I think Xanax is probably the only benzodiazepine that you can give that doesn't increase depression, but over a period of time most of those will. You have to also realize that over a period of time benzodiazepines are going to decrease motivation. They're very addictive, and you definitely want to stay away from those kind of medications, even with acute anxiety. Definitely not medications that you want to begin with. Substance abuse, again, many people self-treat, so you have to think about alcohol abuse, cocaine, or other psychostimulant withdrawal is going to produce depression. It's going to kind of send them back the other way. Hypothyroidism, you always want to think about, or hyperthyroidism, especially in the elderly. You want to think about diabetes, hypercalcemia, hyponatremia, especially if they're on a bunch of different medications. It's just something that you always want to think about. Neurologic disorders, you have to rule out MS, a brain tumor, Parkinson's, especially if it's an abrupt onset. We're going to talk about how to work up dementia and those sorts of things when we get to neuro. But with the elderly, they may come in with confusion, and that is a completely different workup when it's an acute onset than it is when it's a chronic type of thing. Infectious disease, some things like mono are going to produce extreme fatigue, so you have to think about that. You have to think about HIV. You have to think about nutritional deficits. B12 especially is one that we can measure, but they are doing a whole lot of research, especially with B8 now. And so all of those kinds of things that you have to think about. Of course, you have to rule out other psychiatric issues like bipolar. Are you seeing them in a depressed state, and do they also have periods of mania? So that's definitely something that you have to assess for. And then is this just a normal grief process? Do you want to treat that, or do you want counseling, or do you want to do short-term medication? All those things that you have to think about. So, and there's a lot of different types of depression. You have to think about dysthymia, which is a very low-level depression, but they tend to be just kind of overall sad, and they do tend to respond pretty well to medications. So, all of those kinds of things, seasonal affective disorder, you need to, talk to them about all of those different things. So it's a pretty long list of differentials when you get there. Subjective data. Of course, you're going to diagnose depression with subjective data. One of the best ways to do that is with a screening, and you can usually do it with just a couple questions. In the past 2 weeks, have you felt down, depressed, or hopeless? In the past 2 weeks, have you noticed a lack of interest or pleasure? So that's kind of the screening. But anytime that someone comes in and there's a possibility of depression, and those are your patients who present with, fatigue, poor sleep, appetite, they have multiple body complaints, they're not feeling well, they're kind of down, all of those you need to think about depression. With bodily complaints, low energy, those sorts of things, they tend to be out of proportion to your physical findings. But you always have to think about chronic fatigue, fibromyalgia, those things that could actually be causing a lot of physical symptoms. You also have to think about domestic violence, because sometimes domestic violence will present with these physical types of symptoms. With psychosocial, you want to know about their current home environment, if they're having trouble in their marriage, if they've recently lost their job, if they're struggling financially. All of those things may make a difference for the patient. Psychiatric, either self or family. Has this happened to you before? Is this something that you struggle with from time to time? Does anybody in your family, parents or anybody like that, had a problem with depression? Bipolar tends to run in families, so that's definitely something, if you're thinking bipolar, that you want to ask about. But depression, as we know, has a genetic component, so always ask about family history. Always ask about suicidal ideation. Have you thought about hurting yourself or hurting someone else? And if so, do you have a plan? And if they do have a plan, then that's a medical emergency, so you have to address that completely differently. Their neurovegetative symptoms I want to talk about a little bit more on the next slide. And these are the kinds of things that people tend to come in with. SIG ECAPS is just a way to help you remember the types of questions that you should ask when you're screening. Sleep disturbance is very large, and most of the time it's insomnia. With atypical depression, they may have hypersomnia and oversleep. A loss of interest, that's one of the 2 questions that we have when we do the 2-question screening. And it is actually a pretty good screen, at least to get started. But we have better screening tools that are more comprehensive, like the PHQ-9, which is, I think, much better. But have you noticed a loss of interest in usual activities or loss of libido? G, are you feeling guilty or thinking badly about yourself? E, have you noticed a decrease in your energy level? C, have you had trouble concentrating? A, have you experienced changes in appetite or weight? P, do you feel physically slow or fast? And S, do you have thoughts of suicide, feelings of hopelessness, or are you preoccupied with death? That will give you a pretty good indication of depression. Objective data. This is kind of where we leave the science and we get into the art a little bit. Your physical exam is going to be based on the symptoms that they give you. You're going to already most likely have a gut instinct that the bodily complaints and all the things that they're talking about are kind of out of proportion to the physical findings. So after a period of time and after you've seen a lot of these patients, you start to get a pretty good feel for, I'm probably dealing with somebody that's depressed at this point. but they are coming in for physical complaints. And if they had a lot of insight into the fact that this was depression, then they would just walk in and say, hey, I'm depressed. That's not how it works most of the time. They come in with physical things. And so if you appear to blow that off and not address the concerns that they have physically, then they're not going to be likely to listen to you later. So showing that you are taking very seriously their medical complaints and doing a really good physical exam, I think goes a long way to establishing that trust that you need to be able to talk with them about what's going on with the depression. So the purpose of your physical exam really is to rule out medical reasons for symptoms, reassure that the patient that medical illness is unlikely, and then, if they're an older person or having any kind of psychotic types of things along with depression, then you want to do your mental status. But you immediately, when you walk in, are going to know their affect, you're going to know their appearance, and you're going to be evaluating their behavior as you go through all of your subjective data.
So this is your DSM-5, a major depressive disorder. You need to have 5 or more of the following symptoms during the same 2-week period, and this has to represent a change in function. At least one of the symptoms either has to be depressed mood or loss of interest. Now, you also don't want to include any symptoms that can be explained medically. Depressed mood most of the day, nearly every day. Markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Significant weight loss or weight gain. Insomnia or hypersomnia. Psychomotor agitation or retardation nearly every day, and this is something that's observed by others. This is your couch potato. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive and inappropriate guilt nearly every day. Diminished ability to think or concentrate or indecisiveness. Recurrent thoughts of death, suicide, or attempted suicide. Symptoms cause impairment in social, occupation, or other areas of functioning. So those were your symptoms. Now we have to say that it causes impairment. It's not attributable to physiologic effects of a substance or other medical condition. It's not better explained by another disorder. And there's never been an episode of mania or hypomania. So remember, to diagnose depression, we have to rule out bipolar. When it comes to diagnostics, your symptoms are going to lead your choices. Now, I do have set ones that I always do. I always do my CBC, because most of the time fatigue is a major component of why they're coming in. And I always do that TSH, because you got to think it's female between the ages of 20 and 40. I've had treated patients who were on Zoloft or another different medications for anxiety, and get a TSH on them, and they're hyperthyroid. So you can increase that medication to the maximum dose, and that's not going to fix the hyperthyroid. So you always have to consider what's underlying this. Are there physical reasons for what this patient is experiencing? And then, of course, your depression screens. It's fine to start with a PHQ-2, ask a couple questions. If it's positive, go on to the PHQ-9 or do the Beck depression screen, whatever works for you in your particular practice. I think most often in primary care, it's the PHQ-2, and if that's positive, then it's a PHQ-9. That's what I've seen most often. Now, whether or not they need an EKG really depends on what you gather from your subjective data and your objective data. And the same with an MRI. I mean, you're not going to do an MRI on people who come in for depression unless there's some other things that are going on. And then if there's a lot of other things going on, then maybe it's not depression, and maybe this is referral to a neurologist. And I guess the one that I think about most often, and why I even bring up an MRI or a referral, is that, I always kind of worry about MS. These are, women in their 20s to 40s who come in with all these weird symptoms, and they really don't match up, and they've been going on for years, and when you see them, it may be perfectly normal, and I always think about them. It's always kind of in the back of my mind to not miss that, to not just assume that it's depression, but to really pay attention to what they're saying and what their symptoms are. And then whether or not you do a toxicology screen, is really based on what you gather with your subjective data. I don't necessarily do it on everyone, although you will see some sources who say to do it. I do it if I feel it's pertinent based on the information that I've gathered. When it comes to management and referral, we can take care of most depression in primary care. I mean, most people are going to respond pretty well to an SSRI. Sometimes the first one doesn't work very well and you need to try a different type of medication, but they are definitely the first line and what you want to try. Now, you need to be aware of also patients that would respond very well to therapy. If you have that available, cognitive behavioral therapy, especially if anxiety is a really underlying, driving this depression a whole lot. Don't forget about exercise. Exercise is every bit as effective as any medication that we can give. Now, sometimes you need to give a little bit of medication to kind of get them started, but what I do is always prescribe them right together. I'm going to give you some medicine. Hopefully that's going to make you feel better in a couple weeks. We'll start to see a big difference at about 6 weeks. Now, another thing that we really need to think about is exercise. Exercise is as effective as any of this medicine that I can give you. So, let's talk about how you could get started doing that. Let's talk about, what's available to you. What do you like to do? And I really go into trying to get them started on some regular exercise. Of course, you've got to treat that underlying cause, just like what I said with the anemia. I mean, it doesn't matter how much I go on her antidepressants or how many I try if her fatigue is created by anemia. So you've got to find those underlying causes and treat those. You want to refer for any patients, of course, who tell you that they have had a period of mania or hypomania, because you don't want to go ahead and get them started on an SSRI, because you can very likely throw them into an episode of mania, and you don't want to do that. We're really not equipped to prescribe antipsychotics in primary care. I mean, you really need to refer for that. There's some great commercials out there. I admit it, they're great, but it's not the kind of medications that we're really, that we know about and that we should be using. And that's my opinion. All right, severe cases, of course, try a couple of different medications. If they aren't receptive at all, if it's not helping at all, go ahead and refer. Get some help with these patients. And of course, never forget to ask about suicidal ideation. Most people that commit suicide have seen a primary care provider in the last couple of weeks, so don't forget to ask that. If they have an ideation, sometimes I think about it. That's a little bit different than, I plan to shut myself in the garage and leave my car running. I mean, they're totally different kinds of things. So an actual suicide plan is always a medical emergency. If someone has attempted suicide in the past, they are very high risk to try it again. So you need to ask that as well. And if they have tried to attempt suicide in the past, that's a referral. You need to get some help with this particular patient. So dysthymic disorder, I wanted to just kind of mention this because this is something that you're going to see a lot in primary care. They don't quite meet the symptoms of major depressive disorder, but they're not quite happy either. They're kind of somewhere in between. So dysthymic disorder is a really chronic form of very low-level depression. They have to have it at least 2 years, and most of the time they'll say that they've had it for years. But they have fewer symptoms than major depressive disorder. So during most days, the patient has 2 or more of the following symptoms. They have a change in appetite, insomnia or hypersomnia, fatigue, low energy, poor self-image, reduced concentration or indecisiveness, feelings of hopelessness, or just real pessimism. So during the last 2 years, at least 2 of these symptoms are present daily for more than 2 consecutive months. So this is your patient who doesn't, quite meet major depressive disorder, but still would do very well with some therapy, maybe a very low dose of an SSRI, and get them on a regular exercise program. It'll just make a huge difference in their quality of life. So the key takeaway here, I know I gave you a lot of information on depression, but it's just so common. Depression is a primary mood disorder characterized by depressed mood or decreased interest in things that used to give pleasure. Remember, one of those has to exist within your 5 symptoms. It's during the same 2-week period, and it represents a change from previous functioning. Depression tends to be a very chronic, relapsing disease associated with significant distress and impairment. It's one of the top worldwide causes of disability, and recurrence is usually the rule. About 1/3 of patients go on to develop chronic depression. Depression is becoming much more of a disability, and it's on its way to becoming the second leading cause of disability. It's important as nurse practitioners to distinguish major depressive disorder, unipolar depression, from bipolar. All patients should be asked about episodes of mania, hypomania, and family history of bipolar. All patients who are talking about depression should be screened at every visit for suicidal ideation. If a patient reveals a plan or intent to commit suicide, it has to be taken seriously and treated as a medical emergency. Any patient with previous suicide attempts should probably be referred to a mental health specialist. They're at much more risk to repeat that suicide, so reaching out and getting some help with this patient would be a very good thing to do. Remember that they're rarely going to walk in and say, hey, I'm depressed. They rarely present with depression, often present with somatic symptoms, fatigue, insomnia, irritability, poor concentration. It's very important to rule out physical illness that may be either causing the depression or mimicking the symptoms of depression. When you identify depression, always also screen for substance abuse disorders. Remember that your treatment options include medication, therapy, exercise, meditation. There's lots of things that could help this patient, so make sure that you pull out all the different treatment options when you're dealing with a patient and not just medication.